This is Dr. Lauterbach, and I'm going to give you a quick overview of our week 5, which is chapter 7. We'll talk about the importance of health screening and some key components of health screening in this age group of birth to 21 years, which will include immunizations, vital signs, blood components, growth norms, physical development milestones, mental health, and nutrition. There's a lot of information in the chapter, very detailed information, charts of screening tools, milestones, and expectations, normal things you might ask at different ages. Those are good things to know. I'm not going to expect you to memorize that kind of thing for this course. We are going to talk in detail about vaccinations next week, but what I want you to know is you should understand the kinds of things you need to have screenings for and assessments done, rather than committing to memory all of these various things. It's not advised that you do that. I always, in my own practice, whether it's for vaccines or developmental assessments of kids, I use formats to trigger me to make sure I'm on track with them. I'm not a PNP, I'm an FNP, which means I don't see children all the time, but I do see them frequently. And a resource that I use, and I'll recommend to you if you're in the FNP program, is to use the American Academy of Pediatrics Bright Futures guidelines. We use them in our practice, and I think most practices do. So just a point of, when you look at this chapter, we are not expecting you in this course to memorize all of this stuff. That said, you should have some familiarity of what the Healthy People 2020 objectives and goals are. And the 2030 goals have not changed much for this area, but a lot about early childhood, adolescence, and impacts on mental health disorders. That's because we know that attachment is the big deal for early childhood development, which then carries all the way through to adulthood and is the source of a lot, when it hasn't gone well, can be a source of a lot of mental illness later on. There are things we can do about it, but we need to understand if there were attachment issues, which simply said is the basis of being able to be a trusting adult. That happens in your first year of life. So if we have problems with attachment, we're going to have a lot of problems later on. But depression, anxiety, and psychosis, many of those are genetic. You know, it's in your chromosomes more than in your environmental influences, but it has a very powerful effect. So you will see that over and over again. Immunizations are covered in detail. Now remember, this is a print version, so it goes out of date. They have right in here in the course the cdc.gov vaccine schedules website. I strongly urge you to use that reference when you're in practice, because things change, and things that are seen and in the past were held out as the gold standard, called the Pink Book, which is simply the same information printed in a book that happened to have a pink cover, comes from CDC. I don't use the Pink Book because the Pink Book could be published this year, 2 years ago, 3 years ago, depending on the version you've got. So it's so much more reliable to simply use the web page, or if you have the app on your phone, it's the same information. It's very convenient. We have a lot of issues now, especially post-COVID, with vaccine hesitancy. We don't really have a lot of discussion in this chapter about vaccine hesitancy, because this was probably being written during the pandemic. But there's a lot of research now coming out about vaccine hesitancy on the part of parents and on the part of adults about themselves. But what we know is that vaccines are extensively researched. They are safe and effective, and they don't cause disease. They offer some findings from studies They bring up on this slide the Prevnar 13 study. Prevnar is a pneumococcal vaccine which has been really effective in reducing community-acquired pneumonia from pneumococcus and other pneumococcal diseases, FYI, but we usually think of pneumonia. But the point of the study, and the reason I think they put it on this slide, is that that was one of the real cornerstones of the idea that you can give multiple vaccines on the same day. You really don't have to hold back. And in fact, many preparations have multiple vaccines in them. There are some rules you're going to learn about next week from our guest lecturer, Kay Frederick from the health department. With live vaccines, there's a 28-day window. If you give one, you don't give any more for 28 days. But you can actually give, and we do routinely give multiple live, attenuated live virus vaccines on the same day. Then you got to wait 28 days after that. But she's going to cover that. I'm not going to say more about it right now. When we move on to physical screening, talk about growth charts, APGAR scoring right off the bat, at birth and 5 minutes after. Newborn screenings, there's tables, charts, all kinds of great information in the chapter on this. Again, what I use is a publication in the American Academy of Pediatrics called Bright Futures. And when you get into your FNP PEDS classes, you will be using that guideline. And they break it out by age. It's very straightforward. I absolutely urge you to do that. Beyond just physical screening, there's developmental screening. How are kids coming along at these various milestones shown on this slide with their motor development, with their sensory development, with their cognitive and language developments? These are the things that we're really looking at. Here we're talking about school-age screening. So the data comes from the NANIS 1 and 2 data sets to determine reference for treating lead levels in children's blood, and it should be checked every 4 years on this slide. American Academy of Pediatrics has a recommendation. We are screening every kid we can find in the first year of life for lead. They need to get a lead test. It's a simple thing from a finger stick. You generally do them in the office. You don't have to send them out. But lead screening, we have found out, because lead poisoning really gets in the way of cognitive development, and it's lifelong. You can't fix it once it's, you can treat lead poisoning. I don't mean to say you can't fix that, but the developmental delays tend to be pervasive and persistent. So we really want to be on top of that. And we, living here in Michigan, had that experience in Flint with the water supply being contaminated, and it was a pediatrician who raised the concern, like, wait a minute, I'm seeing all these kids with developmental delays, and when I'm testing them for lead, it's up there, something's going on. And of course, you're probably familiar with all of that. But the American Academy of Pediatrics says you need to do kids either at 6, 9, or 12 months. They don't really care which visit, but it ought to be done by a year. And then again before they start school. So that's what the American Pediatrics says. If you have a kid, however, that is at high risk for environmental exposure to lead, you would screen them more frequently. At a minimum, the kids who you think have no real risk of lead exposure, living in high socioeconomic status, living in a safe environment, in a new home, not old paint, the new plumbing, all this stuff we think about, kids not exposed to any of it, you still screen them, okay? And you screen them at either 6, 9, or 12 months, and then again before they start school. And the school systems require this, at least the pre-check before starting school. You're doing hearing screening, vision screening, general physical assessment, listening for murmurs, basically, and then abdominal screening is usually about abdominal defects like hernias, bulges, the little things that happen on kids' bellies. Some of them go away, some of them don't. The ones that don't, you're going to have to either monitor them closely for development or send them over to surgery and have them corrected. We also have neurological screening, musculoskeletal screening, tell if kids, so when you think of MSK screening in the school age, you're thinking about scoliosis, you're thinking about valgus and varus deformities of kids, sometimes foot, ankle. They start as bones are growing at this age group rapidly. We start seeing pigeon-toed, splay foots, all kinds of different things start showing up. So the kids, when they're coming in for this kind of age group, coming in for screening, you need to get them down to their underwear and have them walk around and watch what they're doing. That's basically how you do it, although the textbook gives you really nice pictures of what it looks like, all that. For this course, all you have to know is we're doing musculoskeletal screening. Skin screening, school age, usually that happens in the babies. You'll see, sorry for bouncing around here on you, skin screening in the school age, look to see if they have any lesions or anything unusual. But babies, we're checking them for cafe au lait, we're checking them to see if they have dimples over the base of their spine, indicating they might have some problems like subclinical spina bifida, that kind of thing. Here's a little test yourself question for us. So if you're doing a developmental assessment on a 13-year-old, what are you going to focus on? Which of these seems to be appropriate to things you'd really wonder about for a 13-year-old? Would you check to see, are they able to reason and understand? Can they sit and concentrate on work? Is their thinking logical and systematic? Are they able to consider a hypothetical question? Well, the answer is because development, of course, is developmental. The other milestones in that question, so the answer, by the way, is able to consider a hypothetical situation. That's something you expect to see developing at ages 12 to 15. So in a 13-year-old, that's really what you're focused on. Their ability to reason and understand, sit and concentrate, and thinking is logical and systematic is earlier. Those are tasks that need to be completed at entering school, not at age 13. However, I would say this, when you see kids, you need to find out what kind of health care have they had, or even adults for that matter. Schools are very helpful to us in the United States because they have standards for screening that have to be done for that kid to get into school. But you are going to see immigrant families coming here from places where that has not been done. And you're going to find things in 14-year-olds and 15-year-olds and 22-year-olds that will surprise you because they will be deformities, or they will be developmental delays, or they will be things that nobody has really addressed from a healthcare perspective because they simply haven't had preventive care. So you have to think about that when you're seeing all ages, certainly through early adulthood. And adolescence, we have a lot of immunization surveillance, making sure things got done, more physical evaluation and screening. From late childhood into early adolescence, we're looking at secondary sexual characteristics, which is the Tanner scoring, nutritional issues, depression, suicide, and risky behaviors. With the growth coming in adolescence, we're looking at scoliosis incidence, not just in females, but it is higher in females. And so there are some very simple screening tests. They outline them in the textbook, but basically you need to have the shirt off and the kid bend over, touch their toes. You're standing from behind and you're looking to see, is there a deviation of their spine? It's really simple and quick, doesn't take but just a second. And then if you have a suspicion, you get some radiographic, you just get an x-ray. And the radiologist is going to report back any deviations for scoliosis in terms of the degree, and anything over 10 is something we're going to have to watch, and anything much over 15 to 20 is something that, they're going to be off to the spine surgeon. So those are things you're looking for. That's kind of the physiological stuff. The psychological stuff just gets to be extraordinarily important and hard to figure out when you're seeing kids, but you're thinking about, anorexia, bulimia, and not just in females. Yes, it's more common in females, but it happens in males as well. Obesity happens in both, and it is really, really common. Body dysmorphic disorder, kind of, that happens not just with females or kids who identify as female wanting to be skinny, but also this, we're calling it now muscle dysmorphia, where you'll see young men, young young males, trying to build muscle mass when they don't even have, they're not physiologically ready to build muscle mass, and they can do damage doing it, lifting too much, changing their diet in a way that isn't helpful, and that sort of thing. How might you see this stuff? Well, here's a question. You're the APRN, you got an adolescent patient, you're doing a physical on her, and she's got a couple of things you see. Which ones make you wonder about eating disorder? Acne, inflamed parotid glands, a blood pressure of 110/70, which by the way would be normal, and a heart rate of 88. Well, you probably figured out it's the parotid glands. Acne is not associated with an eating disorder. It's genetic mostly. Blood pressure, hers was normal, would be low in a patient with an eating disorder. Yeah, probably. Not so sure that that would be your trigger of you to think eating disorder. But, you know, if a low heart rate bradycardia, that's kind of odd. You'd want to find out about that, and that could be a bad eating disorder. But the kids don't look right. Frankly, when you see them, they look hectic. They aren't having muscle development the way you want to see it. There's a lot of other things besides what they point to here. But that inflamed parotid glands comes from repeated vomiting. And then we've got mental status screening. Depression is so common. We're also very worried about depression leading to suicide and other risky behaviors. So it's important. When you're coming up through your assessment class, you're going to get quite a bit of content on this and how to go about it. There are a couple programs specifically about how to assess teenagers for these sorts of things, and you'll see that. But just to know, suicide and depression are really, really important, that you're screening for it and looking for it and thinking about it when you're seeing adolescents, both men and women. And then the sexual stuff. They're starting to become sexually active. We need to talk about that and find out what their risks are, and do they have the right vaccinations, and do they know how to have safe sex? Do they need contraception? Those are things that need to be asked, and they need to be asked privately without the parent. And sometimes that gets a little dicey, but that's just too bad. It's manageable. You'll figure out how to manage it. Your practice, wherever you are, will have ways already established for how to deal with that. And that's kind of the chapter.